Okay, thank you. That was a sort of an in-depth delve down into a particular case study around a particular decision in a particular clinical setting. What I wanted to do was to give a sort of a broad view of some of the other bits of learning that are emerging from the programme as a whole today. And so some wider examples of early learning, and this is still early learning, and some of this we are testing, if you like, against this audience as well. Do some of our early conclusions make sense? One of the things that's been encouraging, I think, in listening to some of the other case studies is the common sorts of conclusions that we're coming to in a number of implementation projects. So maybe when you reflect in the final session today, final session in thinking this through against the frameworks and models, you might think about that. So a few other key lessons that are coming through. One is this issue about fitting decision making or decision support to clinical pathways. We can't necessarily just parachute something in and expect it to work. Sometimes the pathway has to adapt to take account of a tool, or the tool needs to be designed to take account of a pathway. This is an example in obstetrics in Newcastle, where we're looking about decisions about women who've had a previous caesarean section and whether they should have a trial of labour or so-called vaginal birth after caesarean VBAC, or go for an elective caesarean section. And we've changed the pathway, at least in a component part of our delivery here within the obstetric clinical team, such that the adaptive pathway now allows for women who are coming to their initial antenatal clinic to have in advance information, the knowledge requirements to enable them to understand the decision that they're making and the risks, benefits and consequences of those decisions, and also an adapted Ottawa decision guide so that they can work through on a sheet of paper their thinking in advance of the clinic, so that when they first come and see, in this case, a midwife, they've already started to think through what's important to them. They've thought about what do I need to understand, what do I need to know about making this decision, such that the consultation then becomes a different type of consultation. And that's led to an adapted pathway to enable that to happen, but it's also led to, certainly the centre and the midwives involved in this, women making better informed decisions in the same way that you've just heard described in the breast cancer setting. So there's an issue that's emerging about pathways and how they adapt for shared decision making. The question about clinical skills development. I guess one of the things that we're learning, and as you've heard it from others, is that this isn't just about tools. So we've developed advanced skills training, which is interactive, initially started off as 3-hour workshops with actor, patients, role play, where we were getting senior clinicians, both consultants and nurse practitioners, to come along and work through the model that you saw earlier that Glyn showed, the skills that might be needed to support a good shared decision-making consultation. We've had to adapt that, we've had to shorten it. We couldn't get senior clinicians, particularly consultants, to come along and give 3 hours. So we've had to adapt that to the group that we're working with, but it nonetheless seems to be really important. So the skills development is as important, we would argue, as the tools themselves. Clinical team engagement, I think one of the things we've learned here is, maybe it's no surprise, and we've heard it again from others, is the importance of champions, leaders within teams. That you've seen 2 of them sitting up in front with us today. But it's not just a single leader often. It's about leaders across the team, bringing different skills and different contributions to those teams. It might be the technical knowledge, or it might be the shared decision-making skills. We found in particular in primary care that learning sets have been really important. So those teams of champions that I described earlier, the GP, the practice manager and the nurse practitioner, then get together in learning sets across those practices and share what they've learnt and go away with new ideas from, well, you did this, we did that, what worked, what didn't work, And that interactive learning is really important. And it's been important between Cardiff and Newcastle and the teams meeting across the two sites as well. We've had to work, and we continue to work on this concept of transfer of leadership. How do we shift this from being a magic project, Glenn mentioned this earlier, to something that the teams themselves do and see as their own ownership rather than something that we've brought in to help them to do. And we've also observed that for different teams there are often different facilitators. For one team it might be that they're most interested in their patient experience or in decision quality. You've just had a very good example of that. In another team, you might like to comment on this, Sheila, the fact that there was a new development, a midwife-led birth unit, offered an opportunity to introduce the concept of shared decision-making in a new setting. We've talked a bit about the marketing, social marketing, awareness raising. That's been important. We've done some of the similar things to what Dominic described earlier today in terms of raising the profile of Magic to our clinical teams. But we've moved now on to social marketing towards patients, the 3 questions approach, getting patients to understand how they might influence their consultation by seeking to answer questions in advance. Interestingly, we've ended up with 3 different questions in Newcastle and Cardiff, so there's something here about tailoring for a local population. So in Cardiff, we've got what are my options, what are the possible benefits and risks of these options, and what are the likelihood of those benefits and risks. When we work with our clinical teams and our patients, most importantly, in the same way that Cardiff did, we ended up with a different 3rd question. How can we make a decision together that is right for me? Now, I don't know which of those 3 questions is right, but actually they came from us working with the patient body itself, and they told us in Newcastle that they found that helpful. We will see. So we do need to, I think there's an issue there about adaptation to a local environment as well. Measurement, you've heard a very good example in the breast care team in Cardiff, but one of the things about measurement in this area, it's awfully difficult. Trying to measure patient experience and patient engagement in shared decision making close to the consultation, we found one of the most challenging things to do. We find major ceiling effects when we ask people, were you engaged as much as you wanted to be in decisions about your treatment and care? That same question that I showed you at the beginning, where only 50% say that they are when they're surveyed 6 weeks after being an inpatient, when we present that same question to patients after they've just been in a clinic, we get 90+% saying they were. So there are some challenges in doing that at a very local level, which is partly probably to do with social acceptability bias, and we might argue what those issues are. But one of the challenges is measurement is tough in a form that actually makes a difference in the clinical team itself, which is where the decision quality instrument may have been particularly valuable, because it was integrating with clinical practice and clinical care. But we have found that implementing a way of thinking around rapid quality improvement, rapid testing, has been important in a number of areas. This is the sort of questionnaire we use and have developed to try and access shared decision-making experience at the local level. Don't worry about the details of that, but we've now got that down to about 4 or 5 questions that ask them about were they told about choices, were they told about options, were they told about the risks and benefits, and were they engaged as much as they wanted to. And these are the ones that have tended to be rather ceiling effects, but it varies. So when we look at, here's an example in the place of birth work, which is a new area, there is quite a lot of variation in whether patients agree or disagree regarding these questions. So most feel that they were given the choices, but the proportion who were told about the pros and cons of that choices varies. So there is some variation there, but it's not to the level that we see when you ask that question at a population level, if you ask it close to the clinical consultation. There's work to be done here. It's tough and challenging. Patient and public involvement, we found, I suppose if we were doing this again, we would start earlier. It took us a while to get things up and running in both of our settings, in getting patient and public involvement teams together. Once we did, we found them really helpful. They challenged us, which was really important. And as we've already seen, they've been really important in helping us to work through those issues about what sort of questions would you like to be asking, what sort of words make sense to you. And so they've helped us very much in designing some of that content of the social marketing to patients. There's a big question there. Again, I think we've heard it in several discussions already about, well, what's the right time to do this? What's the right time to, I don't like the term, but patient activation. Do you do that at an early stage, or do you wait until your clinical teams are ready to respond to it? And again, I'm not sure we have that question yet resolved, but it's still an important question. Organisation and policy support, at the moment, I think, has a variable impact. I think it's fair to say. You saw yesterday from Steve and his team how much emphasis there is in national policy around shared decision making. No decision about me without me. If you use that phrase with our clinicians, it polarises them. Half of them say that's wonderful, we want to do that, and half of them say that's just Andrew Lansley's idea, it's a slogan. It's very interesting how, at a local level, those national policy initiatives can be differentially interpreted. Getting board level and middle management engagement is tougher. So we've been pretty good, I think, at the sort of clinical team level. Not got it right, perfect, but we've learnt a lot from that. Getting middle management and senior management engaged is a tougher task, and that's really something that we want to work further on in the planned phase 2 of this. And we do see a lot of competing incentives within the healthcare system in which we work. So some of the feedback that Steve gave before lunch regarding how do you engage senior management is really critical here. It's not whether their patients in their hospitals are involved in shared decisions is not keeping them awake at night. It's not bothering them in the same way as their financial probity is bothering them, or their waiting time targets are bothering them. And indeed, some of these targets and incentives are competing. If you have to move patients rapidly through a cancer pathway, for example, does it really give time for a proper shared decision to take place? And we've had some success, I think, in both sites in linking some of what we're doing to existing initiatives. So in Cardiff, linking it to your quality improvement structures and the 1,000 Lives campaign, so linking it to safety in Cardiff has been important. So very quickly then, what would we say were our key learning points to date? Firstly, this key barrier, we're already doing it and it's too hard, it takes too long, which when you think about it is contradictory in itself. That's a challenge. Much more than PDAs, the skills development and new ways of consulting are as important as decision support. They go hand in hand. Complex PDAs have a role, but we also need simpler in-decision, in-consultation decision support. We need to embed these in clinical pathways, and we're having discussions now about how we move this upstream from secondary care to primary care, for example, in discussions around lower urinary tract symptoms. And again, we heard earlier about moving decisions about osteoarthritis up into primary care. The important and emerging role of patient activation, and we're provided the service is ready to respond, arguably. Measurement at a local level is tough, but you could argue it's something of a holy grail, that, because without measurement, how do we know we're doing it, and how do we engage our clinicians in understanding that they're achieving what they're seeking to achieve? The potential to link to QI and service improvement, and these wider challenges of how do you incentivize things within a system, because we're working from the bottom up, if you like, starting with clinical teams and working up to an organisational level. One of the questions you might think about in your reflections after this is how do we bring that together with the sort of top-down approach that Steve and his team discussed yesterday from an NHS level? Can we map these two together so that they're mutually supportive? One further thought here. Much of this at the moment, we're all talking about a very reflective approach to understanding what does and doesn't work. Measurement's still quite tough. So we often have to ask ourselves, how can we be sure that our interpretation of what we're seeing is actually correct? I'm reminded of the statement that it's not until you look at an ant through a magnifying glass on a sunny day that you realise how often they spontaneously combust. That's not what I think we're learning here. And I think what we are hearing is similar outcomes, similar observations across the range of implementation programs that we're talking about.